We'll be discussing in brief the management of specifically T3 laryngeal cancers in this video. T3 supraglottic cancers involve the pre-epiglottic space, the paraglottic space, the postcricoid area, or the inner cortex of thyroid cartilage. And T3 glottic cancers involve spread to the paraglottic spaces, and fixation of cords in either a supraglottic or a glottic cancer will make it T3. The pre-epiglottic space is commonly confused with the vallicula, which also lies in front of the epiglottis on laryngoscopic examination, but the vallicula lies above the hyoepiglottic ligament. The pre-epiglottic space is below the hyoepiglottic ligament, bound anteriorly by the thyrohyoid membrane and posteriorly by the epiglottis. Most importantly, the pre-epiglottic space is not seen on a laryngoscopic examination. The pre-epiglottic space is continuous bilaterally with the paraglottic spaces, which are bilateral spaces. These are all one continuous space containing fat. The paraglottic space is bound medially by the quadrangular membrane and the conus elasticus, which is the equivalent of quadrangular membrane extending from the true vocal cords below, laterally by the thyroid cartilage and the thyroid membranes. So the main question that we need to ask ourselves uh, to decide which of these options, so many options to choose from in a T3 laryngeal cancer, is whether organ preservation is feasible and advisable for this particular patient. This is a very beautiful depiction of the changing trends in treatment practices for laryngeal cancers. The initial standard of care was total laryngectomy followed by adjuvant radiation. Partial laryngectomies, which had gained favor in between, had lost favor again, being performed very rarely now. Chemoradiation and biological agents are being increasingly used. So, for years, advanced laryngeal cancers were treated by total laryngectomy and adjuvant radiation. But obviously, nobody wants to lose their voice. So, patients had an entire intense desire to retain their larynx. Um, so the first landmark organ preservation trial was the Veterans Affairs Laryngeal Cancer Study Group trial published in 91. So the control arm was the then standard of care, that is total laryngectomy with adjuvant radiation. The experimental arm was 2 cycles of induction chemotherapy, cisplatin 5-fluorouracil, and a response assessment. If the patients had at least a partial response, then they went on to receive the third cycle of chemo and radiation. If the response was less than a partial response after 2 cycles of chemo, then the patients were sent for a salvage total laryngectomy. So 166 directly underwent laryngectomy. Of the 166 in the experimental arm who underwent 2 cycles of induction chemotherapy, 30 had to undergo salvage laryngectomy before starting the radiation. So by study protocol, they had less than partial response after 2 cycles of induction chemo. 18 other patients completed the chemotherapy, then had at least a partial response. So, chemotherapy, radiation, everything completed. After completion of all treatment, they had persistent disease. So, these patients had to undergo laryngectomy for persistent disease. 11 other patients had to undergo a late salvage laryngectomy for recurrence. So, chemo, radiation, declared disease free. Then after some time, the disease recurred, so underwent total laryngectomy. So, total of 59 patients of these 166 had to undergo a laryngectomy, amounting to 36%. So, that concludes the trial. Larynx preservation rate was 64% in the Veterans Affairs trial. Most importantly, this larynx preservation of 64%, that is 64% of the entire study population of the experimental arm, could retain their larynx without compromising on the survival. This is the most important point to remember, because if the survival was compromised, there was no point in retaining the larynx. So, without compromising overall survival, the larynx could be retained in 64% patients. There were a few other important lessons that were learned from the VA trial, that larynx preservation was less successful in a subset of patients. That is, these subset of patients required salvage laryngectomy more often than not. Patients with T4 tumors that is outer cortex of thyroid cartilage invasion, gross cartilage destruction, or exolaryngeal disease, they failed in achieving a good control with organ preservation, and they required salvage laryngectomy more often than not, and more often than T3 tumors, and more often than patients without cartilage invasion. Very similarly, patients with fixed cords required salvage laryngectomy more often than patients with mobile cords. Stage 4 basically means either a T4 tumor or a bulky nodal disease. So these patients obviously required salvage laryngectomy more often than T3 tumors with a non-bulky nodal disease. So the crux, the final lesson learned from the VA trial was that patients can retain their larynx without compromising on overall survival, but it will not be successful in all the patients. There are a few subset of patients where organ preservation is known to fail or is expected to fail. That is patients with T4 tumors, gross cartilage invasion, and high stage tumors, probably very bulky nodal disease tumors. They are more likely to fail organ preservation. So there was this criticism that all this chemotherapy was not required at all because just radiation alone historically was offering similar control rates that were seen for T3 tumors in this trial. So the question was whether the chemotherapy helped at all. Was there any benefit in adding chemo over the radiation? And if the chemo had benefits, what is the ideal sequencing? This was answered in the subsequent landmark trial, the RTOG 9111 trial. So there were three arms, radiation alone, 70 gray, and this was the experimental arm of the previous trial. That was the control arm of this trial. So this is now a new standard. This standard is proved that it is equal to the conventional standard of total laryngectomy oncologically. So now this standard is a control against which the experimental arm was compared. The experimental arm was concurrent cisplatin with 70 degree of radiation. This is a very interesting trial. The results of this trial has been a matter of so many panel discussions and debates. We'll be discussing these in a slightly greater detail. So we learned from the VA trial that bulky T4 tumors with gross cartilage invasion, they are known to fail organ preservation. So these patients were excluded from the RTOG trial, and also a lot of patients in this trial had N2 disease. So if a patient had N2 or N3 disease at baseline, a planned neck dissection was recommended. This is very, very important to note that a significant number of patients in all the three arms, especially the concurrent chemoradiation arm, 25% had N2 disease. There's a very common misconception that nodal disease is a contraindication for organ preservation. It is not a contraindication per se. We can still attempt organ preservation. There may be a chance that the nodes may not respond as well. In that case, if the primary response and if the nodes do not, the patient can still undergo a salvage neck dissection alone, sparing the larynx. So we will be seeing the results of this also subsequently. So just note that a significant number of patients in all the three arms had N2 disease. Now, this is a very commonly talked about topic. So, the orange being the experimental arm, it offered the best loco-regional control, as in it kept the disease under check. So, after the completion of concurrent chemoradiation, there was no disease, there was no persistent disease, and the disease did not come back easily. So this is loco-regional control, right? So the loco-regional control, if the patient had good loco-regional control, obviously there was no laryngectomy. So the loco-regional control curves and the laryngeal preservation curves fairly parallel each other. But the laryngeal preservation curve and laryngectomy-free survival curves are not similar. This is because in this Kaplan-Meier curve, if a patient underwent a laryngectomy, the curve drops. That is all that mattered. It did not even matter if the patient was alive or dead or if the patient's disease had come back. Laryngectomy, the curve drops down. No laryngectomy, the curve is straight. But in this, if the patient had either a laryngectomy or if the patient died, the laryngectomy free survival drops and the Kaplan-Meier curve drops. So that is why this difference between these two endpoints of laryngeal preservation and laryngectomy free survival. So it was very clear that the locoregional control and larynx preservation were best with concurrent chemoradiation. That is the experimental arm of this trial. But ultimately, laryngectomy free survival was not so superior. It had actually started dropping towards the later years, and it had dropped even below the control arm of induction chemotherapy with response assessment. That is the blue line. The reason for this we'll be discussing in the subsequent slide. It is also important to note that the overall survival, though numerically is better in the control arm of the blue line, the induction chemo with response assessment, was statistically not significant. All the three arms had a statistically similar, not very significant difference in overall survival. So, this disparity between the larynx preservation and laryngectomy free survival was explained by the unusually high number of deaths in the concurrent chemoradiation arm due to causes that were random, that were not related to the cancer and not related to the treatment complications per se. So, the 10-year follow up of the RTOG 91 trial, the author's words, there was no difference in the 10-year cumulative incidence of toxicity between the three arms. The reason for the increase in late non cancer deaths remains speculative. Objective assessment of speech and swallow function was not available for all the patients, but overall, roughly, there was no significant difference in late toxicity or speech and swallowing function as per the authors of this trial. But it's a very well known speculation, and it's a very common point in panel discussion debates that the most probable cause of such unexplained high deaths was aspiration pneumonia. It is also very important to remember that chemoradiation can alter the functionality of the larynx. So, a patient's larynx may be decently functioning at the baseline before starting chemoradiation. With chemoradiation, because of the fibrosis, the functionality may worsen. The larynx may lose its function, and that might have caused recurrent aspirations causing aspiration pneumonia, which were probably not recognized, and that is why these deaths were marked as unrelated to the cancer treatment. So it is very important to objectively assess the larynx functionality even after the completion of chemoradiation. There's another very important point to remember from this trial, that the target radiation dose was 77 gray, and patients who received less than 66.5 gray were very minimal in all the three arms. That is, there was a very strict adherence to treatment protocol, very low rates of treatment discontinuation. More than 80% completed their treatment. This is not applicable to the general population, where there may be, especially in India and in resource constrained settings, where there may be a very high chance of treatment discontinuation due to multiple factors. So, from these two trials, it was obvious. Now, total laryngectomy was the standard of care, and in the VA trial, it was seen that organ preservation is possible without compromising overall survival with induction chemotherapy and response assessment, which then became a yardstick. And the next experimental arm was compared against that yardstick. Concurrent chemoradiation also had very similar overall survival, though there was no head-to-head comparison between concurrent chemoradiation and total laryngectomy. It is an indirect comparison, but still, The overall survival was very similar between the concurrent chemoradiation arm and the induction chemo response assessment arm. And it was very clear that best locoregional control and larynx preservation were seen with concurrent chemoradiation, but there were a significant amount of late deaths, probably due to treatment related toxicity and silent aspirations, recurrent aspirations. So this became the then standard of care, concurrent chemoradiation for organ preservation. There have been so many modifications henceforth in the organ preservation protocols, and the one other validated modality is the GOTIC trial protocol, where a triplet regimen, docetaxel, cisplatin, 5-fluorouracil with radiation or chemoradiation, is validated for organ preservation. There are other modifications like altered fractionation of RT or radiation with targeted agents like cetuximab, etc. So ultimately, we have come to the end of our discussion. Our aim in treating T3 laryngeal cancers is not just retaining the larynx, but to retain a functional larynx so that the patient will be able to eat without aspiration, and the patient will be able to maintain the airway, not requiring a tracheostomy, but at the same time without compromising survival. So when we are considering organ preservation, we should not include patients with gross cartilage destruction or significant exolaryngeal disease, that are T4 tumors basically, because we know that we will be achieving an inferior oncological outcome. We are going to fail locoregionally. So specifically for T3 tumors, the factors to be taken into consideration while making the decision are: first, logistics, patients, motivation level, including where they live. We need to objectively assess if the patient is going to discontinue treatment due to logistical reasons, etc. And most importantly, before considering organ preservation, all patients should undergo an objective assessment of laryngeal function with a fees, and a PAS score should be calculated. A PAS score of more than 7 is a strict contraindication for organ preservation protocols. Again, to emphasize, nodal disease is not a contraindication. Persistent nodes after chemoradiation can be treated with a salvage neck dissection. So the first question is: the larynx worth conserving by a functional assessment? If it's not worth conserving, total laryngectomy radiation straight away, no questions. It's worth conserving, it's a functional larynx in a T3 tumor, then we will aim to conserve this larynx by all means. And we will try to do it non surgically as the first step. So we evaluate fitness for the patient for chemoradiation. If the patient cannot take chemotherapy due to comorbidities, frailty, poor performance status, or advanced age, or if the patient cannot take radiation therapy because of prior radiation to the neck, then the patient cannot undergo chemoradiation. Straightforward. The next question: is voice conservation surgery feasible? Generally, if a patient cannot tolerate such chemoradiation, those patients are not likely to tolerate voice conservation procedures also, because voice conservation laryngectomies have a very stormy post-op course causing significant aspirations. So patients need to be young, fit, and perfect pulmonary functions to tolerate voice conservation partial laryngectomies. So if voice conservation is not possible, then the only left option is a total laryngectomy. So upfront surgery is preferred in certain circumstances, the non-squamous histology, and as we said, very young patients, radiation can cause second cancers. So to avoid radiation, young fit patients who are expected to have better pulmonary functions and are expected to tolerate partial laryngectomies better may be served better with a partial laryngectomy if anatomically the tumor permits so. And there are certain circumstances where the RTOG 91 experimental arm, that's a typical induction chemotherapy response assessment arm, can be used. That is an acceptable alternative. That's a very good alternative. There are situations like these are examples like a bulky nodal disease. For example, a patient has an end to very bulky nodes, bilateral nodes. So, but the nodes are resectable at present. Imagine sending this patient for chemoradiation and the nodal disease progresses or does not respond. If the nodal disease progresses to become unresectable, involves carotid or prevertebral fascia, then we lose a chance of cure. And also, these patients have a very high chance of metastatic disease. So, early initiation of chemotherapy may be helpful in controlling such micrometastatic disease. So such patients may be triaged with an induction chemotherapy. Also, this is another set of patients who are amenable for partial laryngectomies at present. And if we send them to organ preservation chemoradiation, we know approximately 75 to 80% of them are going to succeed in organ preservation with chemoradiation. But if they fail, it will be a salvage total laryngectomy. So we have a patient, a young fit patient, feasible for partial laryngectomy now, feasible for a supraglottic partial laryngectomy now. We send for chemoradiation. The patient does not respond so well. We have to do a total laryngectomy. So in such patients, we may use induction chemotherapy as a litmus test to assess response. And if they have a good response, organ preservation. Otherwise, we can straight away go ahead and do a partial laryngectomy, which is feasible at that point of time.